The next will be Dr. Caleb Ho. Caleb did his residency at Yale University, and he did his Heme Path Fellowship, so we're really going to be diverse over here. Heme Path Fellowship at the Brigham, and he was our molecular fellow until 2016, 15 to 16. And then he's now heme pathology, hematopathology, and molecular pathology, and his interests are actually lymphomas, right? Yeah. And everything else. Okay.
Okay, thank you for the introduction. And today I'm going to share with you a very interesting case of a patient with two different lymphoma coexist in the same area. And based on the differences in the immunophenotypic profile, initially they were thought to be separate lymphomas. But as I'm going to demonstrate to you in this presentation, based on a combination of cytogenetics and molecular studies, we're able to demonstrate clonal relationship between the two lymphomas. And I'll also talk about how proving that clonal relationship make a difference in the patient's prognosis and treatment plan. So this is my disclosure. And this is a 48-year-old male patient previously diagnosed with CLL/SLL in 2006, treated with fludarabine, cyclophosphamide, and rituximab with good response, but eventually the disease progressed in 2013 to 2014, and he was switched to ibrutinib, which is a Bruton tyrosine kinase inhibitor. In August 2017, he presented with pancytopenia, increased FDG uptake in the marrow, diffuse lymphadenopathy, and splenomegaly, consistent with disease progression. At that time, the CBC showed elevated white count of 27.6 with mostly abnormal lymphocytes. There's also marked anemia and marked thrombocytopenia with elevated LDH level. So bone marrow biopsy was done because of the imaging finding. And instead of having normal marrow architecture, the marrow is diffusely replaced with a population of monotonous-looking abnormal lymphoid cells. On closer power, most of the cells in the marrow are these intermediate-sized cells with round to slightly irregular nuclear contour, fine to dispersed chromatin pattern, some with prominent nucleoli, which suggests a more aggressive process rather than just a CLL/SLL. But in some focal areas, there are cells that look more like typical CLL cells with small size, more condensed chromatin pattern, and distinct nucleoli. This is a touch imprint from the marrow, showing, again, mostly cells that are a little bit larger in size with fine chromatin and prominent nucleoli consistent with a more aggressive process. So the flow cytometry in this case really helped us to make the diagnosis. By flow cytometry, we're able to identify two abnormal B cell populations, both are CD19 positive, represented by blue and orange. The green cells are the normal T cell for comparison. So the blue cells represent the CLL population that is CD5 positive, variably positive for CD20, likely this is to be expected in CLL/SLL, and the patient also have received rituximab in the past, which can downregulate CD20 expression. The CLL cells are kappa restricted and negative for CD10. On the other hand, the orange population, also a B cell population, are mostly negative for CD20, also kappa restricted, but have CD10 expression. Other immunophenotype, CD38 was bright for the orange population, the CD10 positive B cell lymphoma population. They are negative for CD23 and negative for CD200. And because they look a little bit blastoid looking, we also did some additional markers, including TDT and CD34, and they are negative for those markers, telling us that we're not dealing with a B lymphoblastic leukemia here. The CLL population, on the other hand, has typical marker that you expect for CLL, including bright for CD200 and CD23 expression. So this is a brief comparison of the immunophenotypic profile based on flow cytometry. The CLL population has typical marker expression that we expected, while the CD10 positive B cell population doesn't have CD5 expression, doesn't have CD23 or CD200 expression. So these two populations are very different. We also did some immunostains on the marrow. CD3 highlights some scattered T cell. CD20 is variably positive, but mostly negative in the lymphoid cells, again, because of the history of rituximab treatment. PAX5 and a B-cell marker is diffusely positive. Ki67 is very high, again, goes along with an aggressive process. CD5 is positive in the T cell and the CLL cells, while CD10 is positive in the more aggressive-looking lymphoma cells. 23 is partially positive, and left one is another marker for CLL, which is also positive in the CLL cells. We also did some general center markers, including BCL6, because as you're aware, when you have a CD10 positive B-cell lymphoma, you think about things like follicular lymphoma and diffuse large B-cell lymphoma, GCB type. And BCL6 is negative in this case. MUM1 also seems to be mostly negative. LMO2 is another general center marker that's negative in this case, and cyclin D1 was negative. BCL2 mostly highlight the T cells and negative in the B cells. And interestingly, c-MYC appear to be highly expressed in the aggressive lymphoma cells. CD34 and TDT, these are markers for immature cells, and they're negative. So this is a huge summary of all the markers that we've done so far. But the key thing that you can get from this is the CLL population has very typical marker expression for CLL, while the CD10 population has very different immunophenotypic profile and also high expression of c-MYC. So just by glancing at the immunophenotypic profile alone, you think that these two tumors are different, even though they coexist in the marrow. So to further study this case, we utilized flow cytometry for sorting. So we sorted the sample into the two population of lymphoma cells and sent them separately for cytogenetics and molecular studies. So first we did FISH probe for TP53, which is located in chromosome 17p. The red probe represents TP53 probe, while the green probe represents centromere 17 probe. In the CLL population, there is a loss of TP53 in the majority of the cells, while in the CD10 positive lymphoma, there's no loss of TP53 that we can see by FISH. When we use break-apart probes, the probes are green and red, and normally they should overlap with each other, giving you a yellow signal. So this is the normal pattern. And we saw a normal pattern in the CLL population, but in the CD10 B-cell lymphoma, we saw evidence of MYC rearrangement where the signals are apart from each other. And this goes along with, by immunostain, we're able to see overexpression of MYC in the aggressive component. We also did SNP array, single nucleotide polymorphism array. This is a test done at the cytogenetics lab where we can look at the copy number alteration across all the chromosomes in the tumor. And besides copy number changes, we can also see any loss of heterozygosity. So in this case, comparing the results from the two tumors, in chromosome 13q, there's a very focal area where there's a loss that is seen in both lymphoma components. And both also show some alteration in 17p, which is where TP53 is located. Now, zooming in a little bit closer, for the CLL component, in 13q14 region, there's a homozygous deletion of RB1 and homozygous deletion of ZDB2. And in the CD10 positive aggressive B-cell lymphoma, in the same region, there's homozygous deletion of both genes. Zooming in into the 17p region where TP53 is located, the CLL cells show loss of 17p that you can see here. The CD10 positive aggressive B-cell lymphoma did not show any copy number change. However, there is evidence of copy neutral loss of heterozygosity, CNLOH, in that region. And we a lot of times see CNLOH in the context of a coexisting mutation, where one allele is mutated and it gets duplicated, resulting in both of the alleles having the mutation, but the overall copy number is still normal. We also send the flow cytometry sorted sample separately for impact study, which is a 400 gene hybridization capture based NGS panel. And we can look for both mutation and copy number changes using a panel. And this is a summary of the findings in the sorted populations. Interestingly, both tumors show identical mutations in SF3B1, which is a mutation that can be seen in CLL, as well as an identical mutation in TP53 and UBR5. Additionally, each tumor also shows some unique mutation not found in the allo tumor. The CLL population show multiple TP53 mutations. Both of these tumors also show a mutation in KMT2D, but in different locations. On the copy number side, both of them share deletion of ZDB2 picked up by the NGS panel, and this is consistent with what we saw by the SNP array analysis. TP53 alteration, also seen by the SNP array analysis, as well as RB1 deletion, but in different exons. And the CD10 B-cell lymphoma also show evidence of IGH-MYC translocation that was detected by FISH. So far what I'm showing you here is we have two tumors with very different immunophenotypic profile, which seems like they are unrelated to each other. But now on a molecular level, we have some evidence that they share clonal relationship because they have multiple identical point mutation as well as deletion in the same areas. And to provide some further evidence that they're clonally related, we performed the IGH gene rearrangement study on the sample. This is the B-cell clonality study. And we use the NGS-based method where we can compare the actual sequence of the clones rather than just comparing the size of the clone, which is what you usually do in gel or capillary electrophoresis-based assay. So in the unsorted sample, the CLL sample, and the CD10 positive B-cell lymphoma sample, we saw a single identical clonal sequence in all of these samples. And this here provides some further information on the clone that was detected. It is 293 base pair in length with this particular VJ usage. And the IGHV mutation status is unmutated. And as many of you are aware, for CLL cases, unmutated IGHV status is usually associated with poor prognosis. So the final diagnosis for this case, we have evidence of CLL-SLL, which is the minority of the tumor cell in the marrow, as well as a high-grade B-cell lymphoma that's CD10 positive with evidence of MYC rearrangement. And despite the differences in the immunophenotype, they are clonally related as demonstrated by shared mutation and the identical clone demonstrated by IGHV gene rearrangement studies. So at this point, you may wonder, what is the importance of proving a clonal relationship between the two? Is it just an academic exercise? If they know the patient have an aggressive B-cell lymphoma, wouldn't they just treat it the same way anyway? It turned out that in the case of CLL and Richter transformation, the treatment choice and prognosis can be very different if the tumors are clonally related versus not clonally related. There are large-scale studies out there that look at patients with CLL as well as a subsequent diagnosis of large B-cell lymphoma. Majority of the cases, in the majority of the cases, the CLL and the aggressive B-cell lymphoma are clonally related, and those are what I call true Richter transformation cases. In the minority of cases, the CLL and the large B-cell lymphomas were clonally unrelated. So the de novo large B-cell lymphoma would have developed probably independent of the CLL progression. And when comparing the de novo cases to the Richter transformation cases, the de novo cases in general actually have more complex genomic alterations, and they are not exactly the same as what you see in Richter transform cases. But they actually have better survival. We're talking about median survival of years. On the other hand, for Richter transform cases, the genomic complexity is not as great, but the patients have much worse prognosis with a median survival less than a year. For de novo cases, the clinician can potentially treat with R-CHOP or R-EPOCH, and that can be curative for the patient. But for Richter transform cases, those regimens will be considered suboptimal. And the oncologists will usually try to consider autologous or allogeneic stem cell transplant for these patients. So making that distinction actually does make a difference in this case. And since we're able to prove the clonal relationship between these two tumors, the clinician treated this patient differently as a result. So I just want to quickly go over Richter transformation. In a few studies that came out 5 to 6 years ago, this is one of them that came out, looking at the genetic alterations in Richter transform cases, they can be broadly divided into 3 groups that you can see here. The largest group consists of cases with TP53 loss or mutation, or CDKN2A loss, as well as MYC gain or translocation, and 13q14 loss. And our case actually, they fall into this group. The large B-cell lymphoma, the aggressive B-cell lymphoma in our case actually have most of the alterations in this group. The second group consists of cases with trisomy 12 plus or minus NOTCH1 mutation. The NOTCH1 mutation is usually acquired at the time of disease progression. And then there's a third group that consists of various alterations. And another thing I want to talk about regarding Richter transformation is, in the majority of cases, the CLL, SLL undergo Richter transformation in what we call a linear pattern disease transformation. So this is pretty straightforward. The CLL cells accumulate more mutations over time, eventually transform into large B-cell lymphoma. If it's a linear pattern of disease progression or transformation, we'll expect the aggressive B-cell lymphoma to harbor all of the mutations that you can find in CLL cells, plus some additional mutations. On the other hand, in the minority cases, the tumors can undergo what we call a branch pattern of disease evolution, where it is hypothesized that there's a common neoplastic progenitor that give rise to different lymphoma over time, and each of these lymphoma progress separately by accumulating more mutations. So in this pattern of disease evolution, you expect the tumors to share some mutations that are found in the common neoplastic progenitor, but because they evolve independently over time, they will also harbor some unique genetic alteration. So from the molecular profile in our case, the tumors seem to follow more of a pattern of branch pattern of disease evolution rather than a traditional linear pattern of disease transformation. So as a follow-up on a patient, because of refractory relapse disease, he received EPOC, IVAC, and eventually venetoclax, which is a BCL2 inhibitor, and Pembro, which is a PD-1 inhibitor. And as I mentioned before, in a patient like this, they would consider allogeneic stem cell transplant. But in this case, it was delayed because of patient complication. And the patient unfortunately passed away in April 2018. So that comes to the end of my the interesting case I presented, and because this case was so fascinating, we wrote it out as a case report, and it was actually just published online last week, so this just came out. And I just want to thank Priya Kumar, one of our former hematopathology fellow, Manik Oppo, who's a Cornell medical student, for writing up this case report and submitted for publication. I also like to thank other members of the molecular lab and the HemePath service, as well as some of the clinicians that provide help to us, including Jay Park from the leukemia service and Anita Kumar from the lymphoma service. And that's the end of my talk, and there's some references here. Okay.
Any questions? Is there a relationship with the unmutated and hypermutated CLL to the transformation? Like your case was not mutated.
Yeah, so the unmutated cases are usually more likely to transform. And this is referring to the IGHV status.